Thank you for the introduction. Hopefully in a second, everyone can see this and everyone can hear me. Let me know if not, and I'll go ahead and get started. Good afternoon, or I think it's hopefully afternoon for all of us. Again, my name is Hersh. I'm a third year PhD candidate in biophysics at UCSF in San Francisco. And today I want to share with you a project of mine relating to trying to use artificial intelligence to improve the way we diagnose and treat prostate cancer, and in particular, alleviate the racial disparity that exists between Black and white patients in prostate cancer through personalized medicine. So to start off with some background on this racial disparity, prostate cancer, unfortunately, has the highest incidence among males of any cancer in the United States, and in addition, has the greatest racial disparity between Black and white patients of any cancer. Black patients experience nearly a twofold greater risk of developing the disease and more than a twofold greater risk of experiencing disease-related death. This is a disparity that cannot completely be explained by differences in access to care or socioeconomic status. Indeed, current research suggests that there are biological differences in the disease pathogenesis and cancer biology between Black and white patients, which result in this more severe disease in the Black community. However, despite this racial disparity and these biological differences, prostate cancer is currently treated in a race-agnostic fashion. The protocols for diagnosing and treating prostate cancer don't differ between these high versus low risk subsets. So the question motivating my research was, how can we do better, both for the treatment of all prostate cancer patients, but especially with respect to this racial disparity? To understand how we went about improving and developing tools for improving prostate cancer diagnosis and treatment, let me share a little bit of background on how some prostate cancer patients are diagnosed and treated. In particular, I want to emphasize a subset of prostate cancer patients, about 75,000 of them in the United States every year, for whom radical prostatectomy is prescribed as a therapy that's intended to cure these patients of disease. Radical prostatectomy is a surgery in which the prostate is removed, and the goal is to remove the cancer cells along with the prostate and leave the patient cancer-free. Unfortunately, a large fraction of patients who undergo this invasive surgery, more than 1/3, experience recurrence of disease in the days and months following surgery. However, if we could somehow know which of the patients are in this 1/3 category who will experience recurrence, we could prescribe them additional therapies that would reduce their risk of relapse. And we could also spare the remaining 2/3 of patients from having these invasive and aggressive treatments like adjuvant radiation or chemotherapy. So this is where we focused in on trying to improve our ability to predict who are the high-risk patients versus the low-risk patients. Let's take a look at how traditional risk estimation works in prostate cancer. This table you see on the right is what clinicians use to score patients between 0 and 15 with a score that attempts to predict their risk of disease recurrence following surgery. You can see here that a variety of different clinical variables or parameters are taken into account, and depending on the level of certain measurements from the blood of biomarkers, some measurements from the tumor that's removed, and other aspects of the surgery are taken into account to derive a score. Where we in particular wanted to make an improvement was in this specific subset of the score called the pathologic Gleason score. This is something which I'll illustrate a little bit what it is, and then we can see why it needs some improvement. The pathologic Gleason score is determined after prostatectomy when the removed prostate is sectioned and slides are prepared for a pathologist to look at under the microscope, and the pathologist then essentially assigns a score, which is called the Gleason grade or the Gleason score. And the pathologist under the microscope attempts to estimate how disordered the tissue is. We know from many years of cancer biology that more disordered tumors are associated with higher degrees of metastatic tendency and higher degrees aggressiveness in general. So this is sort of a 5-point score, and it's scored as a primary score and a secondary score, where we take into account this information about the structure of the tumor. And depending on how disordered the tumor is, we can try to estimate whether the disease will be aggressive or not. But let's take a look at exactly what the pathologist sees under the microscope when they get these slides. On the left here, we have an image of a prostate quarter mount slide that we scanned under a microscope. And on the right, I've blown up a small inset of the tumor region. And what you can see here is the prostate tissue in writ large, and also the tumor subset. And this is what the pathologist looks at and attempts to calculate these scores. But as a computer scientist, the first thing that was striking to me about this approach is that it's highly reductive. There is a huge wealth of information in an image like this. In fact, in this particular image, there's about 24 billion bits of information. And that's being reduced through this process to only 6 bits of information, orders of magnitude of a simplification. So the question we asked is, this Gleason scoring and this approach to treating and developing treatment strategies for prostate cancer has, almost pre-existed modern computing. So now in 2021, can we use computers to take advantage of this image, and this tumor slide information in a more sophisticated way? So what might that look like? Well, what we thought we might want to build is a sort of architecture that looks something like this, where we could take the tumor slide, which is already routinely prepared after radical prostatectomy surgery, scan it under a slide scanning microscope, so we have a digital image just like the one you see on the left here, and then feed this into a computer model that could estimate whether the patient is at high risk of recurrence or low risk of recurrence. And computers have the capability, unlike a pathologist sitting at a microscope, of literally measuring and making complex calculations that are derived from millions of different, or even many millions of different aspects of the tissue structure. So to get into how this could work and exactly what goes on here, let me give you a very simplified lesson in pathology and histology. And I'm by no means a pathologist, but this is pretty much my level of understanding. If we look at this image here, this is what a pathologist would see under the microscope in a specific region of view. And I'll draw your attention to 2 or 3 different things that we can see, so you can make a little bit of sense of what we're looking at here. These small purple spheres or little purple circles are nuclei in the tissue, the nucleus of different cells. And you can see those exist throughout, and some of them are more elliptical and some of them are more spherical. The second thing we have are glandular structures. These are these large circular regions or elliptical regions with a white lumen or space inside. And those are, they're critical to how the prostate functions in secreting different substances. And then finally, we have something called the stroma, which is this red, almost diagonally striped or striated regions, which form the parts of the prostate between the glands and other structures. So the question became, pathologists and you and I even can conceptualize of these different aspects of the tissue morphology. And you might even, if you were trained for a little while, like pathologists are through many years of actual education, learn how to perform Gleason scoring yourself, come up with these standardized estimates of tissue disorder. But for a computer to do that is a really hard problem. And we look to a method called deep learning, which has become quite famous in the last few years. And what we did was essentially have pathologists take a pen to these images and manually circle nuclei and stroma and glandular regions, and use that information to teach the computer to recognize the same regions in these images. And you can see here that this actually worked really nicely. In the middle here, here's a deep learning model that was designed for the computer to figure out where the nuclei are. So in white here, this is where the computer thought there were nuclei in this image. And in white on the rightmost image is where the computer thought there were stromal regions, which are these red regions again. And once we got this working effectively, we actually had something that was a much simpler problem. This was really the hard part of getting a computer to understand tissue morphology, because for many years, long before anyone thought about how to even treat prostate cancer, people have been doing geometry. And so once we had this map, which is essentially a bunch of coordinates of where the nuclei are and where the stroma is and where the glands are, we could use years and years of math that people have worked out to measure from this data descriptors of the shape and arrangement and texture and orientation of all of the nuclei, really millions of nuclei and hundreds of thousands of glands and different stromal regions within the tissue. And these metrics have an advantage of being actually measured very precisely. We know exactly what the distances are, what the shapes of different elements of the tissue are. And here you can see sort of a representation of what the computer sees when it looks at these images. And it's really very sophisticated. What we identified, interestingly, in this study is that some of these measurements that we calculated are correlated with the disease aggressiveness. We had patient data sets where we knew how aggressive their disease was, and we found that some of these scores are very much associated with high risk or low risk of cancer recurrence after surgery. That enabled us to feed this information into computerized models, which are actually machine learning models, and train computers to look at these measurements, computer-derived measurements of tissue morphology, and predict patient risk. And this is where we found really probably the most interesting finding of this study, which is that when we train models that were specific to Black or white patients, the population-specific models dramatically outperformed models that were trained in a population non-specific fashion. And this strongly supports the need for personalized medicine models that take into account things like genetic origin or background, especially in cases where we have diseases that have a strong component of population-specific disease biology. It turned out that the models that we developed, and this is just sort of the general architecture, but these models turned out to outperform the current clinical standards for Black in the Black patient data sets of this study, and perform nearly on par with the current clinical standards for white patients. We essentially published these results in clinical cancer research earlier in the pandemic, and have filed for a patent for this technology, such that we hope that one day we could leverage these algorithms to actually predict risk for patients who have undergone radical prostatectomy, and clinicians are trying to decide whether or not to prescribe further lines of therapy. With that, I'd like to thank my collaborators on this study. This was an effort from many different institutions, with collaborators spanning from biostatistics to biophysics to computer science to oncologists and pathologists. I'd finally and importantly like to thank the ARCS Foundation, of course, for supporting this work, Jill and everyone for coordinating this event and inviting me to speak, and my fellow speakers as well for taking the time today to discuss this most important disease. Thank you very much.
Thanks, Hersh.